Hello, everyone. Thank you for joining today's briefing. Confronting the mental health crisis, the value of a team-based approach. I want to note that today's briefing will be recorded, and our team will provide the recording as well as slides and other resources to all attendees. Next slide, please. My name is Len Marquez. I'm Senior Director of Government Relations at the AAMC. The AAMC leads and serves academic medicine. That includes all 156 accredited USMD medical schools, 400 teaching hospitals and health systems, and nearly 80 academic societies. Through our work, we represent hundreds of thousands of medical students, resident physicians, faculty members, and researchers. Next slide, please. It's also important to highlight our members' unique role and the disproportionate amount of care they provide to their patients and communities across the country. Every day, we work with our members to improve the health of people across the country through medical education, patient care, research, and community collaboration. Next slide, please. I especially want to thank our congressional partners and champions, specifically the Congressional Academic Medicine Caucus, led by co-chairs Reps Kathy Castor of Florida and David McKinley of West Virginia. And I'd specifically want to flag Nora Blaylock and Janine Bender, our staff contacts in those offices who have been such great partners. It's now my pleasure to introduce Representative Castor to explain the role of the caucus and the purpose of today's briefing.
Hello, I'm Congresswoman Kathy Castor of Florida, the co-chair of the Congressional Academic Medicine Caucus, along with my colleague, Congressman David McKinley. The bipartisan caucus was created to educate members of Congress and their staff on the critical role of medical schools, teaching hospitals, and faculty physicians in improving the nation's health. And I want to thank the Association of American Medical Colleges for convening this briefing, and our behavioral health providers for sharing their expertise. Academic medical centers are vital to providing cutting-edge medical research and training that benefits patients and communities. In my Tampa Bay area district, I've witnessed firsthand the value of the University of South Florida, Morsani College of Medicine, Tampa General Hospital, and the James A. Haley Veterans Hospital. Everyone who is working as part of the mission, they are tireless in their teaching and training each and every day. And all of you were a particular godsend during the global pandemic. Thanks to academic medicine, we've made great strides in combating COVID-19, but the pandemic had a profound impact on the collective mental health. And many Americans continue to struggle. The pandemic has been particularly devastating for young people, prompting pediatric organizations to declare a national emergency in children's mental health. So now, more than ever, Americans need access to timely, affordable, and accessible mental health care. And AAMC and their members around the country are working to meet this demand, investing in new team-based models of care that promise to extend the workforce, expand access, and combat stigma. And so today you will hear from behavioral health experts across the nation about how they are working to expand access to mental health care in their communities and how Congress can support them in their important work. So thank you for attending this discussion. I look forward to our continued collaboration in improving the mental health of people across America. Thanks again.
Thank you, Congresswoman, for those very kind remarks. Next slide, please, Valerie. Thank you. As healthcare providers, our members are deeply familiar with the serious impact of the COVID-19 pandemic on our nation's mental health and well-being. Our community and patients we serve are suffering, and therefore, it is more important now than ever that we invest in our behavioral health and workforce infrastructure. I'm proud to say that the AAMC and our members have answered and continue to answer the call to address this crisis. Expanding access to mental and behavioral health care is a core component of the AAMC's strategic plan. And I'm grateful to my colleagues, Dr. Rosha McCoy, AMC's Acting Chief Healthcare Officer, and Jennifer Fairberg, the AMC's Director for Advancing Clinical Leadership and Quality, for leading this work and partnering with our members to bring this forward. I also want to thank my colleague Sinead Hunt for planning today's briefing and the entire team she's worked with to bring us this far. Next slide, please. I'm also proud to note that the AMC Research and Action Institute, the association's own think tank, has made a priority to research and identify actionable solutions to expanding access to behavioral health care. In fact, just yesterday, they released their latest issue brief on this topic. This will be made available to all participants. I highly encourage you to read it, and please reach out with questions or concerns. So without any further ado, it's my great pleasure to introduce our panelists. Today, you will hear from Dr. Amit Shahane from the University of Virginia. Dr. Shahane will provide an overview of the continuum of integrated behavioral health care. Dr. Rachel Weir from the University of Utah will describe how she leverages technology to facilitate collaboration between providers. Dr. Lisa Ramirez from the Metro Health System in Cleveland, Ohio, will share how her team has leveraged integrated behavioral models to eliminate the wait time to see a pediatric behavioral health provider within their system. And finally, Dr. Anna Ratzliff of the University of Washington will share how she is training the next generation of providers in integrated behavioral health care models. Next slide, please. Now, I'm going to hand things over to Dr. Shahane to kick us off.
Thank you, Len. I first want to begin by thanking you all for giving us the opportunity to talk about integrated behavioral health, something I know we're all passionate about and hope will provide better access to mental health care for all patients. As mentioned earlier, my name is Amit Shahane, and I'm a clinical psychologist and associate professor at the University of Virginia Health System and School of Medicine, where I direct our Behavioral Medicine Center. I've worked in multiple integrated behavioral health settings, from primary care to more specialty care clinics throughout my career. I'm going to start this portion of the panel by describing first the traditional model of behavioral health and contrast it with integrated behavioral health, and also how integrated behavioral health represents an important pathway in getting more people the mental health care that they need. Next slide, please. So in the traditional model of behavioral health care, a patient and their medical provider meet for an appointment. The provider identifies a mental health issue such as depression or anxiety or substance abuse and makes a referral to a specialty mental health clinic. This referral may be across a specific health system in another clinic or to community providers. It's then left up to the patient to connect with that mental health provider. And this is one of the biggest problems in this model, which leads to poor access to services. There can be significant delays in services, especially for patients who are low income or economically challenged due to a variety of factors. There may not be enough mental health providers due to workforce shortages. If you've ever tried to find a mental health provider, you'll likely find that providers won't be taking new patients due to high volume demand, and many community providers may not take insurance, thus leaving a patient on their own to find alternative mental health resources. In the event that patients find a mental health provider, there is limited, if no, communication between that provider and the referring medical provider, contributing to less than ideal care. It's clear that this model alone can't solve the mental health crisis facing our country. So what's the answer or alternative to solving this problem? Next slide, please. Well, integrated behavioral health offers a unique solution to the problems in the traditional behavioral health model. Integrated behavioral health blends care for both medical and behavioral health concerns in real time, thus providing comprehensive or whole person care for patients. Integrated behavioral health care teams include primary or specialty care medical providers and behavioral health clinicians working alongside each other. Primary or specialty care medical providers may include physicians, nurses, physician's assistants, working with behavioral health clinicians who may be a combination of psychologists, psychiatrists, psychiatric nurse practitioners, and social workers who are all embedded together within a single clinic. In the image below, We can see that the patient in an integrated behavioral health clinic has the opportunity to meet with a host of providers within one integrated visit, ensuring that they receive comprehensive care and, more specifically, access to behavioral health care. Another key facet is that integrated behavioral health utilizes a population health focus, which addresses the health of an entire population rather than just one individual at a time, thus increasing access to mental health care for many more patients. Next slide, please. To give a more concrete example of how patients and providers work together in integrated care, one example is at UVA primary care. And I'd like to walk through a common patient visit so you get a chance to see how this works. At UVA, a patient has an appointment, is seen by their medical provider, and at that visit, this provider identifies a mental health issue, such as depression, anxiety, any problematic behavior the patient expresses, such as quitting smoking or taking medication more regularly. Different from the traditional model of behavioral health, the provider consults during the patient visit with an on-site behavioral health provider and receives guidance, maybe on effective treatment planning, potential interventions for the patient, and/or any medication recommendations. At this point, the medical provider can initiate a warm handoff to the behavioral health clinician, who then meets with the patient to provide direct assessment and treatment, schedule any follow-up visits, or link the patient to long-term behavioral health care. This is just one of many examples of how integrated behavioral health provides whole person care. Here, the patient's needs are met during the same visit, thus increasing cost effectiveness and further reducing the burden on an already taxed mental health system. Next slide. So why should you promote integrated behavioral health? For starters, there's a wealth of evidence showing this model is effective. We know that integrated behavioral health increases access to mental health care for our most vulnerable populations, historically marginalized and low-income communities who otherwise may never get an opportunity to receive behavioral health services. Subsequently, integrated behavioral health significantly reduces wait times for patients to receive mental health care. In the previous example, the patient was able to be seen the same day, as opposed to potentially waiting months for specialty behavioral health care. This model also increases engagement and linkage to specialty mental health care in the community when we need to. Behavioral health providers in an integrated setting can make a more targeted referral to specialty mental health providers in the community, often based on the type of mental health concern and knowledge of community provider availability. All of this increases the likelihood that patients will attend those appointments and therefore access and engage more longer-term care. As I'm moving down regarding efficiency, we know that medical providers in primary and specialty care clinics often have 15 to 20 minutes to see a patient. And having an on-site behavioral health provider that's easily accessible helps them have a more focused medical appointment, as they don't have to spend as much time managing behavioral health concerns. This also extends the behavioral health workforce by allowing providers to see a broader base of patients, thus following this idea of population health. Not surprisingly, integrated behavioral health improves outcomes of mental health, lowering symptoms of depression and anxiety, reducing emergency room visits for mental health issues, as well as earlier detection and intervention of substance use. Maybe most importantly, patients really like this approach of integration and whole person care. I recently asked two of my patients about what they thought of this model, and they said, one, I really like the one-stop shopping and having both of my doctors in the same place. Another patient said, I don't have to spend more money driving to different places and dealing with the hassle of making a bunch of appointments. But it's not just patients who like this approach. Medical providers often experience less burnout, increased satisfaction, and a higher sense of effectiveness when integrated behavioral health is part of their practice. I hope this provides an overview of integrated behavioral health and why we need it and how it's effective. At this point, I'll turn it over to our next panelist, Dr. Weir, and look forward to any questions you may have at the end. Thank you for your time.
Okay, thank you. I'll be speaking today about the role of technology in improving delivery of mental health care, especially using technology in the integrated care settings that we're discussing today. So my name is Rachel Weir. I'm a psychiatrist and the Chief of Mental Health Integration for the Huntsman Mental Health Institute and University of Utah Healthcare. So when most people think about using technology in mental health, they tend to think about a few things. One is the growth of electronic medical records, and also technology to help us arrange virtual care or telemedicine or telepsychiatry. So these are both critical developments in the past few decades, but there's also many other potential applications that tend to be overlooked for using technology to expand access to mental health services, both currently and in an ideal future state. So we're suffering an unprecedented increase in mental health concerns among both children and adults, and there's a limited supply of mental health professionals. So what we try to do with technology is not replace the human element of treatment, but how can we use technology to supplement what we do as mental health clinicians to spread our reach even further? Next slide. This is a continuum that demonstrates some of the possible uses of how we can use technology to benefit us beyond just virtual visits, help improve care and outcomes, and close some of these access gaps. So I already mentioned virtual care. This is extremely important, but virtual care alone does not actually improve access to care the way some of these other services can that I'm going to talk about today. So others, just to be mentioned briefly, are digital self-help resources and practice extenders. There's a number of internet-based therapies and self-directed approaches that can provide some immediate access to mental health help for patients. Provider or physician-focused education and decision supports are another development. Importing treatment modules for common mental health conditions into EMRs that can assist physicians who are trying to give mental health care to their patients. Collaborative care is a breakthrough development in treating common mental health conditions in primary care. And through remote monitoring and oversight from centralized centers, we can ensure a high level of fidelity to the model and access to clinical expertise no matter where a patient lives. So across all levels of care, it's important to think about technology in screening populations, helping get people to the right level of care for their need, and then measuring and tracking illness severity. So the two areas I'm going to focus on today are identifying populations of need outreach through automated means, and then also technology-assisted provider-to-provider electronic consults. So next slide. Technology-assisted consults can take many forms. The one I'm going to talk about today is the development of e-consults or electronic consults. Next slide. E-consults for mental health have been deployed in many of our academic medical centers across the United States, including my own. E-consults allow for a primary care or specialty provider to receive a consult on one of their patients in the form of an electronic record. So this can occur provider to provider or physician to physician without the need for an in-person appointment. So this is helpful in several ways. First of all, the provider typically asks a much more focused question than they do for an in-person appointment. And they can get some input on their patient's mental health care and next steps for treatment within days, sometimes even hours. So this can provide nearly immediate access to some psychiatric guidance. Next slide. In addition, the consulting psychiatrist is able to provide input on many more people in this model as compared to usual care. So as a psychiatrist, I can complete 4 e-consults in the same amount of time it takes me to evaluate and treat just one person. And I can also use e-consults to triage people and get them to the right level of care. I've mentioned using technology to expand the reach of mental health professionals. Well, in this model, you'll see that using traditional work allows a psychiatrist to treat 4 new people in a half day. But by adding other methods of consultation through technology, that number of people a psychiatrist is consulting on is multiplied. So it's extremely critical we begin to think about how to use some of these models and these types of services because of that shortage of mental health professionals that we're experiencing and the growing demand. So next slide. The other area I'd like to highlight is proactive outreach for people who need intervention with a population-based approach. So many people that suffer from mental health disorders, they're not easily identified. They often don't ask for help. They don't notify their provider that they're in need, so thus they're not referred for treatment. And even when people are referred, there's often poor follow-through on getting those referrals scheduled and seen. And then also, in addition, despite screening recommendations to screen all teens and adults for common conditions like depression, at least yearly, we still lag behind and don't do this universally. So next slide. At University of Utah Health, we've implemented a plan to electronically assign all patients a depression screen in select specialty clinics. This only goes out to people who have not previously been screened or diagnosed with depression. So we're able to do this without placing any additional demand on clinic staff. There's then a report generated within the electronic health record that includes all people who completed a screen and had a positive score. So we then have a staff member from our behavioral health team who reaches out to the patients and offers them an appointment with one of our clinicians. So I'll share an example of this. Next slide. This individual named Mary was due to be seen in pulmonary clinic for follow-up. Now, Mary has complex medical concerns and she'd had a deterioration of her overall health, and this was affecting her mental health. When Mary received the questionnaire electronically ahead of her visit, she was initially reluctant to answer truthfully or even fill it out at all, but she decided to be vulnerable as she recognized that she did have a mental health need that had been growing. She was surprised to get to the end and learn that she had scored in the severe range for possible depression and that a staff member would be calling her. The behavioral health staff member who receives these reports called Mary the following day. They discussed her frustrations over the phone, including exhaustion from advocating for herself and feeling that no one understood her issues. Mary was relieved to learn there was an integrated behavioral health program within her clinic and that she would be able to see a clinical social worker within 24 hours. She got to the point on the phone where she was able to laugh and express gratitude that she was honest in completing the questionnaire and that someone called her to connect her to care instead of the other way around. Mary said she would not have brought these issues up with her treating medical provider, and she kept the appointment with the social worker, and she's now engaged in skill-based therapy within her medical clinic to address both her medical and mental health needs. Now, Mary is someone who would not have gotten help without this approach. In this case, it was the combination of using technology to identify people in need with a population-based intervention, along with the individual follow-up with that very important human element that connected Mary and hopefully many other individuals like her in the future to much needed care. Thanks for your attention. And now I'll turn the time over to Dr. Lisa Ramirez.
Hi, and again, thanks for having us. So I am Lisa Ramirez. I am a child psychologist by training. I am the Associate Director of Pediatric Psychology and an Associate Professor of Psychiatry at the Case Western Reserve University School of Medicine. And as Len mentioned, I'm coming to you from Cleveland, Ohio, from the Metro Health System, which is a public essential hospital that serves Northeast Ohio. And I'm not going to highlight the crisis that is with our youth mental health right now. I think Representative Castor for highlighting that. And there's a lot of national attention to the fact that our youth are suffering. So today I'm going to talk to you about how integrated behavioral health in our system has really improved access and satisfaction to care for children and young people. Next slide, please. So I want to start by talking about a sample of a typical case that we might see, that we might get a call about, right? So let's talk about Donovan, right? Donovan is a 9-year-old boy whose mom is worried about him because the school is saying that he's starting to fall behind in some of his schoolwork, that he's showing some behaviors at school and at home. And so she brings him to the pediatrician, which is a place where she trusts. She trusts the adults. She trusts her pediatrician, and the pediatrician knows Donovan pretty well. So in that traditional visit, right, the mom would come in, bring Donovan, and talk to the pediatrician in that, as Dr. Shahani highlighted, 15 to 20-minute visit about some of these concerns. And the pediatrician typically will validate the concerns, and if they're serious enough, then say, here is a list of community referrals or a list of referrals that you can access to get help for Donovan. And they may say, come back in about a month and let's check in and see how it's going. And in that month, right, the family may or may not have been able to get a visit, may or may not have had that visit, and Donovan's behaviors may or may not have worsened. And there's a lot that can happen in that month. Next slide, please. So in traditional models, right, there's a lot of burden on those top 2 puzzle pieces. And I do see often families trying to navigate how to access mental health, and it does feel like disparate puzzle pieces, not knowing where they fit. So the family is often left with, and the caregivers, of trying to navigate, who do I call? How do I get on a wait list? Does my insurance cover this external provider? And the pediatricians, before COVID, right, many pediatric visits, about half of them had behavioral health concerns. And again, that was before COVID. So we don't know exactly what that looks like now, but I'm sure it's even higher. So for pediatricians and families, that burden is really high of being able to appropriately access and talk about, and then be able to navigate getting to my puzzle piece, right, which is that yellow one, the mental health providers. And so the other thing is, we know that of those external referrals coming in, only about 1 in 4 children and families will actually make it to that first visit with a mental health provider for a lot of reasons, which means that 3 out of 4 children actually don't get to it. And that could be because of lack of resources, lack of access. Sometimes the problems don't feel heavy enough to then go through the rigmarole of trying to get into that mental health provider. And so often there are other supports, maybe or not, that the families are turning to. But again, there is a massive, massive burden on the pediatrician and the families to really try and navigate how to do that and be the hub of communication. Next slide, please. So just as Dr. Shahani had highlighted, right, in an integrated behavioral health model, the idea is that there is no wrong door for the families, right? That a parent, a child can come in and access a whole team of individuals who treat their health as whole child and whole person, right? And so whether they're coming in for a medical visit that happens to have a behavioral health concern, they have access to whoever they need. If they're coming in for a follow-up integrated behavioral health concern, and then there's something medical that comes up, it is a team-based model. And so there is a lot of communication that happens. And again, no matter how they get to us, we are able to access that team. And that picture there is actually a picture of one of our psychology residents in the white coat talking to a pediatrician and the pediatric resident about a family that had come into clinic. And so just to give you an idea of some of the impact that this can have. So in the calendar year of 2021, just on our main campus, not any of our 20 satellite sites, we had 3,725 integrated behavioral health visits from our main campus integrated care clinic. This was a mix of the virtual telehealth visits and in-person clinic visits, but again, almost 4,000 visits that happened in the same place through the same door, where families did not have to navigate phone calls and transportation and all of the barriers that Dr. Shahani mentioned earlier. Next slide, please. So compared to the disparate puzzle pieces that families are often having to piece together themselves, right? I think of integrated behavioral health as more of gears that are turning in response to how these systems are able to communicate. So often in integrated behavioral health models, you have compatible medical records or the same medical record, but we have access to everybody's input, the same location, so the same door. Families, no matter what, in real time, they're able to access all of the team members and be able to feel as though they are addressed as the whole person with respect, with the needs that are coming through that door. And this is really, really impactful for families and for all of the team members. Next slide. I want to talk about just a couple of really interesting points. So often when those mental health concerns are brought to attention, they're sometimes considered the crises, right? The suicidal thoughts, other psychiatric crises. And so in a 6-month period, we looked at some of our outcomes and we identified 103 children or youth that needed some sort of risk assessment. And so typically, whether it be at school or in a pediatrician's office or at home, right, if a child is in a psychiatric emergency, they're going often to an emergency room, which can be a very unpleasant experience. But with our integrated health model, for those 103 children, 93% of them we were able to assess and discharge home with a safety plan, and only 7% of them were identified to actually need inpatient hospitalization from their pediatrician's office, so to speak. So the benefit of this is that they were able to stay out of that uncomfortable emergency room and get connected with long-term support. And also an added benefit is that the families, the medical systems, and insurers were saving money. And our calculations looked at almost $5,000 per patient of those cost savings. Next slide, please. Another outcome just that I wanted to mention was that we were able to secure some funding through fantastic programs like HRSA's Behavioral Health Workforce Education and Training Grant. That was a collaboration between Metro Health and Case Western Schools of Social Work and Nursing, and graduate psychology education funding. And through those types of funding, we were able to, in 8 years with the support, bring through 331 what we call graduates. They're trainees of some sort, like psychology residents, graduate students, psychiatric nurse practitioner students, social work students, psychiatry residents, along with the medical residents, because integrated behavioral health is not necessarily inherent in graduate and medical education yet. That's my hope. And so this is a way of increasing that pipeline of showing what that teamwork looks like, so that these learners can go out and advocate and also potentially build these programs within their future practices. Next slide, please. So if we go back to Donovan, remember the traditional model with the puzzle pieces. Well, in our integrated behavioral health clinic, because this is based on many actually visits that we have, when that mom brings Donovan in to say, I'm concerned because I don't know what's going on with my child, I'm nervous, they're able to hand off to one of us, a psychologist or one of our residents. And in that same day, we're able to talk to the family for 30 minutes or an hour, depending on our clinic visit. We're able to understand what's going on, including anxiety about school, some sleeplessness that could or could not be related to the fact that he's snoring that mom hadn't brought up before, and so we make a referral back to get him assessed for sleep apnea, but also give the parents some coping around anxiety and give Donovan some strategies to work out at school. We're bringing him back in a week, and in that week, we'll see if the behaviors have gotten better, how the coping is going, and maybe collaborate with school to help school understand how to support him in those. And the main purpose here is that all of us feel effective in our roles, whether that's as a mental health provider, a pediatrician, a parent, and also Donovan trying to navigate childhood. Next slide, please. And so many benefits. I could talk for hours about what I think the benefits of integrated behavioral health are for children and families, but some of the top ones are, of course, increasing access, especially in our case for historically marginalized communities, decreasing stigma, because you're coming to your pediatrician and they're handing you off to a team member, and so it's not you having to seek out additional support outside of that trusted team. And so stigma is a huge issue, especially for our historically marginalized communities. And this has gone a long way to really counteracting and addressing that. We also know that the earlier we can intervene and identify potential problems in childhood, the more of an impact we can have. Lower effort, much higher return on our investment for those mental health initiatives. So prevention and early intervention are a huge benefit. So I'm going to pause there and happy to answer any questions. And I'm going to pass it off now to my colleague, Dr. Ratzlaff.
All right. Hi, thank you so much for inviting us to speak today and listening to these important presentations. My name is Anna Ratzlaff. I am a psychiatrist and professor at the University of Washington and UW Medicine. I direct our residency training program, and I co-direct the AIM Center, which is a national center that implements collaborative care, a specific form of integrated behavioral health. I'm really excited to talk to you a little bit about how we can approach training and educating the next generation of workforce in these important strategies to improve access to mental health care. Next slide, please. So I think you've already heard a bit about the workforce challenges that we have, but I want to just highlight a couple of things with this slide. We have a very limited workforce of behavioral health providers. If you look at this map of the United States, which shows county level data, what it's actually showing is the darker the square, the more access to need challenges there are in that county. So for example, 96% of the counties in the United States have an unmet need for psychiatrists or psychiatric prescribers. We also are hearing a lot about how integrated behavioral health care improves access to care. And that's really important because currently estimates are at least 60%, if not more, of people with depression, for example, and other mental health needs are not accessing the care that they need. Let's go on to the next slide. So I want to talk a little bit about what we need to be training our next generation of healthcare providers in to be thinking about being part of the solution to this very critical problem. So the first thing that I really like to do, I'm going to show you a few of my teaching slides, is orient trainees to the need for population mental health. I think when you're a busy provider trainee in a big academic center or even out in the community, you feel so busy that most of the time you think, I think everybody that might need help. But in reality, that's not true. And often this is really surprising to trainees when you present them with data around the disparity between the access to care and the level of need in their community. And part of the reason that it's really important to orient people to population mental health is so that they're starting to think about how they can be part of the solution to this important national crisis. So one of these slides that I show is this slide. What this shows is that about 60% of people are not accessing any mental health care that have mental health needs. Of those people who are actually accessing mental health care, about half of those, or about 20% of the total population, is accessing that care in primary care. This means that our primary care providers, all those trainees learning to be primary care providers, really need to think about how they might help address mental health needs, and that's why integrated behavioral health is so important. About 20% will see a mental health provider, about half of those will see a psychiatrist, the other half will see some other kind of licensed therapist, psychologist. So what this means is that actually relatively few patients are seeing people in traditional mental health contexts, so that focus on integrated behavioral health is so critical. And there are new learning needs that trainees have to be able to actually deliver care this way. Let's go on to the next slide. So what this slide shows is another important thing that I think our new trainees need to understand, which are what are evidence-based strategies to actually address mental health care, and how does that help us actually address population health needs? So this slide explains collaborative care, which is an evidence-based model of behavioral health integration. On the left hand, you can see that this starts, as most of the speakers have talked about today, with that patient and their medical provider, often a primary care provider, and adds in extra expertise, as we've also been hearing about this morning. In this case, a behavioral health care manager. That person is either located or associated with primary care. They both help coordinate the care of the patient, also being able to deliver evidence-based treatments like psychotherapy right there in primary care. And you've heard how important that same day, same door access is. That the other person that this model adds in is a psychiatric consultant. That person actually leverages their expertise with this team. So they're not seeing patients directly, but rather providing case reviews to that behavioral health care manager. Typically, they spend about an hour a week doing this and can serve a population of 60 to 80 patients. That's a lot more care than if they were trying to see those 60 to 80 patients directly. So you can see how this is really a population level strategy to leverage limited expertise like the psychiatric prescriber to really support that team in being able to deliver evidence-based treatment. In order to learn to work this way, trainees have new learning needs. So these include regular use of measurement-based treatment to target. So this is using measures like a PHQ-9, which is the Patient Health Questionnaire 9, which is used to assess depression, both identify patients with depression needs and also make sure treatments are actually working, so we can repeat that measure. Also, a new skill is learning to use a population registry. This is a list that allows you to track all the patients that need your attention and prioritize where you're focusing your energy energy. For psychiatrists and psychiatric prescribers, you have to learn how to leverage your expertise. This is a really different way of working. You often aren't seeing patients directly, but rather using the information provided by the team to help provide recommendations and diagnoses. Really new skills. So obviously something we have to teach our trainees now, and then making sure that they understand how to deliver a full range of evidence-based treatments in primary care settings. A lot of times these are briefer interventions, and you heard about that through the nice case examples you've already heard today. This model of care is really important to teach because when delivered well, we actually double the chance that a patient will actually have an improvement in depression. So that's the data that you're seeing there on the side. So the collaborative care model is an evidence-based model, been proven in primary care to actually double the chance that a patient will actually have improvement in symptoms. So really important strategy for our learners to be oriented to and be learning about as part of their training programs. Let's go to the next slide. So I want to kind of show you how this all gets put together. So I'm actually going to do a case study of one of our trainees from the University of Washington and how this kind of new way of training our workforce might look. So Dr. Holman was one of our psychiatry residents, and in her 4th year of residency, she decided that she really wanted to go and serve one of our rural communities in Grand Coulee, Washington. This was a community that actually didn't have access to psychiatric prescriber, but she was going to go and work at a community health center in that location and actually deliver integrated behavioral health. In order to prepare her to do this, though, we spent her whole senior year providing mentorship and training around key new learning areas for her to be able to go out and really lead that change to the increasing access to care for that community. So we helped make sure she knew that it was important to think about the need for population health, how to kind of think about the population that she'd be serving, that we introduced effective models of integrating behavioral health and physical care. So she learned about the collaborative care model and all the pieces needed to set that up. We talked a lot about, and she had the opportunity to actually practice doing the caseload consultation or supporting a primary care team here while at the University of Washington while she was a resident. So she was already skilled in those skills necessary to do this when she went out to her new clinic system. And she was able to actually get some mentoring around the leadership, think through the actual workflow changes she needed to do, and the financial model that she actually introduced to the clinic so that they could sustain her working in that practice. So I think this is a really nice example. She went out and then served that clinic within the first couple of months, was already seeing a population of about 60 patients. So you can see that by having this opportunity to train in this model while she was a resident really allowed her to go out and have immediate impact on the communities as she graduated. So I want to conclude by just saying I think it's really important that we continue to support the implementation of integrated care, support the ability for practices to bill and finance this, and then we continue to support ongoing training in this important approach to improving access to mental health care. I will now hand the slides back over to Len Marquez.
Thank you very much. That was amazing. As I'm sure you can all see, how excited certainly I am to work with these colleagues and all the great work they are doing. And I really just want to thank our panelists for sharing their expertise. So as you can see, behavioral health experts at academic medical centers are working hard to improve the efficiency of our behavioral health workforce and meet the growing demand. However, they can't do it alone. We need help from you. Now more than ever, we must invest in our behavioral health workforce and infrastructure, as well as promote parity, integration, and access. Fortunately, Congress, you've recognized this growing crisis, and we're working together in a bipartisan manner to find solutions. We're very excited and encouraged by some of the proposals put forward in this Congress, including 400 additional Medicare-supported graduate medical education positions for psychiatry and psychiatry subspecialties, new demonstration projects and models to strengthen behavioral health network adequacy for Medicaid beneficiaries, the extension of key pandemic-related telehealth flexibilities, in the removal of Medicare's 6-month in-person requirement for telehealth-enabled mental health services, and the elimination of state-level policies to prevent Medicaid reimbursement for mental and physical health services provided on the same day. We are deeply appreciative of this bipartisan effort, and we look forward to continuing to work with you and other colleagues on the Hill to find solutions to this crisis. Next slide, please. While these proposals represent an important step in promoting mental health and well-being, we must do more to strengthen our behavioral health workforce, promote network adequacy, and ensure access to mental health and substance use disorder services. First, it's important to note we are facing a shortage of all physicians, including both primary care and specialists, including behavioral health. And we must build on the bipartisan work Congress did back in 2020 to increase Medicare support for GME for the first time. That was in nearly 25 years. For this reason, we strongly support the Resident Physician Shortage Reduction Act, bipartisan legislation introduced by Senators Menendez, Bozeman, Leader Schumer in the Senate, and Reps Sewell, Katko, Swazi, and Davis in the House. This legislation would gradually increase the number of Medicare-supported GME positions by 2,000 a year over 7 years. The AMC also strongly supports the Opioid Workforce Act, which was introduced in the Senate by Senators Hassan and Collins, and the companion legislation, the Substance Use Disorder Workforce Act, which was introduced in the House by Reps Schneider, Custer, and McKinley. This legislation would provide 1,000 new Medicare-supported GME slots for residency programs in addiction medicine, addiction psychiatry, pain medicine, and the various prerequisite programs. Next slide, please. In addition, as Dr. Ramirez mentioned and demonstrated, the Health Resources and Services Administration Title VII programs, like the Behavioral Health Workforce Education and Training Program, are essential to training the next generation of providers. For this reason, the AAMC is requesting and endorsing for FY23, we urge Congress to provide $1.51 billion for HRSA Title VII and VIII workforce development programs. We must also extend the COVID-related telehealth flexibilities to ensure that Medicare beneficiaries, especially those living in rural and other underserved communities, can continue to access behavioral health care. The AMC supports, and we're very grateful that the House passed the Advancing Telehealth Beyond COVID-19 Act of 2021. This legislation would extend these flexibilities through December of 2024. And we would urge the Senate to act on this to ensure patient access, that patients maintain access to care. And finally, it's time that we stop undervaluing behavioral health care and reimburse behavioral health providers fairly for their work. This is particularly important in Medicaid, where reimbursement is significantly lower. And it's also a key source of coverage for children and moms. The AMC supports the Strengthen Kids Mental Health Now Act, that's HR 7236, which would increase Medicaid reimbursement rates for pediatric mental health services through a 100% federal match. These are all policies that we are working to include in any year-end package, and we would strongly urge you to work towards that once Congress returns in November and December. Next slide, please. And as I mentioned, we are very much looking forward to working with you throughout the end of the year and into the next Congress to continue building and working and to achieve these goals. Before we open it to questions, I just want to reiterate that a recording of the presentation, including our slides, will be made available. And in addition, we will also share our new advocacy resource, or many of our new advocacy resources, specifically the paper from the AMC's Research and Action Institute on Mental Healthcare Access. Now we're going to open it up for questions, and we had a number of questions come in throughout the presentation. And so the first one I'm going to raise is a question. Integrated care is clearly a best practice approach for mental and physical health. With this in mind, what are the barriers that are preventing more from adopting this approach? What can policymakers do to encourage or support expanded uptake in this approach to care? I would turn that to my colleagues to answer.
I'll start with a little bit. I mean, I think that there are a couple of big things. One is this is a lot of work to learn to practice in a different way. And so I think practices often need support to, and that sometimes is financial support, but also training, technical assistance, all of those important pieces to actually be able to transform their practice to deliver care in a new way. So I think that's a big barrier. I think, even in the questions, there were some questions about payment and reimbursement. If you're working together as a team, sometimes you're working in ways that aren't direct service. And so really making sure we have payment strategies that recognize that team-based work. Sometimes the work of doing things like Dr. Weir talked about in terms of maybe not seeing the patient directly, but doing a lot of work behind the scenes in terms of outreach and engagement. Assessing screeners that a patient might be filling out, actually reaching out proactively to patients to engage them. So those are some of the barriers that I think we're still learning about and working through as a healthcare system.
Thank you, Dr. Radcliffe. Did anybody else want to answer that, or?
I would just reiterate that the support, especially like the BWET training, the GPE grant, it has been instrumental in allowing us to continue to expand and really reach more families and be able to expand this, like to Dr. Radcliffe's point. It's not inherent in our training. I think there was a question about when will this be part. I think there's a lot more attention being paid to integrated care and how important it is to teach, but it is not something that we automatically know from grad. So more support in being able to do the training, and it varies by state on the reimbursement. I know somebody asked about reimbursement for psychologists. In Ohio, we have wonderful reimbursement for psychologists doing integrated care. So I think advocacy around that as well is really important.
I would also just chime in and say, I think what I'm hearing from my colleagues is that sometimes it takes a clinic or a primary care clinic to build a culture of integrated care, which can often be difficult to do and be a barrier, especially if current providers and our training future providers aren't used to this idea and model, when to give a warm handoff, when to consult. And so there's a lot of training that needs to happen, as well as the financial backing, as folks have mentioned.
Actually, Dr. Weir, I think we've got a question that pertains to your presentation. As telehealth use continues to grow, more people in rural areas are able to access care easily. How are medical schools addressing the shortage of mental health professionals in rural areas with broadband access?
Maybe someone from the AAMC wants to comment on the training aspect specifically, but I can give you an example of one thing that we did in our state in Utah is provided a statewide grant for small primary care practices in rural areas to allow them to hire and train integrated behavioral health workers, mainly social workers and psychologists, to practice collaborative care. And this grant allowed these clinics to get, to have the hire, to get the startup funds to be able to hire this person until they can get to the point where they're in a financially sustainable model, in 6 to 12 months. So that is one, small statewide solution.
I can add to that too. We also have telehealth competencies that were developed by the AAMC. I'll put the link in the chat for training issues. And we have a whole work stream on telehealth equity, really trying to understand how telehealth is being used to improve access for all populations, particularly those who are challenged with broadband access, et cetera. So I know many medical schools are partnering with their libraries and other places that do have access, that maybe patients could use those places to actually link with healthcare. So lots more to come on this issue.
Thank you, Rosha. So the next question, please address payment barriers. We have this model in a training FQHC and have a health psychology integrated care program. However, Medicaid, insurance, et cetera, do not pay for psychologists in primary care doing this work. What is being done in Congress to address this? Before I turn it to the panel, I would just point out that this is one of the key points and one of the key issues that was identified as part of the Research and Action Institute's work. But with that, I would turn it to our panelists.
I think there is some key work being done with regards to psychology. I know that there's discussion drafts of allowing psychology fellows, for example, to see Medicare patients without a supervising psychologist present for the entire visit and entire subsequent visits. Well, which I think will allow for more patients to be seen and thus more billing. But I agree with the comment, excuse me, that this is an issue and one that I think takes a collective answer to solve. It takes, I think, more advocacy with our insurance providers as well as CMS to increase rates of reimbursement and to specify maybe specific specialty codes for all practitioners.
And I would also just point out from the congressional perspective that certainly this has been part of the conversation. The Senate Finance Committee, Energy and Commerce, Ways and Means, Health. They're all working on how do we address these access challenges. And I think as part of the conversations we have been having on the Hill, I'd certainly recognize that payment parity is critically important and something that needs to be addressed. I think a question we have here, maybe perhaps Dr. Ratzeff, I think this is for you. How integrated present is the collaborative care model and the other skills presented in our nation's university healthcare curriculum?
Yes, so for psychiatry residents, we have milestones which structure what we teach residents, and it is included as part of our consultation milestones. So it is something that programs are expected to try to provide that opportunity for residents to get to see and to learn how they might support, especially primary care providers. There was a study done that's now almost 10 years old that looked across the country and kind of asking how many programs actually delivered integrated behavioral health as part of a training, rotation, or clinical experience. And at that time, about there were only 50, I think, programs that answered, and most of them said they were doing that. But I think those are the programs that are invested because it wasn't a comprehensive study. So we don't have data on currently how many people are doing that. I was involved with the American Psychiatric Association, had a CMS grant, and that we did bring 50 residency programs together to actually learn about the collaborative care model and how to develop training opportunities for that. So I think it's something that we are working on nationally to try to improve access to trainees actually having those services, but available to train in. But I think it's always evolving. So.
Thank you. I think we have maybe time for a couple more questions. I will just quickly hit on one that we hit on the importance of increasing Medicare support for graduate medical education. And the question is, what will the AMC advise to ensure that GME spots are allocated in accordance to need? And I think I would just point out that across the country, we are facing a significant physician shortage, upward of over 130,000 physicians, and that's in primary care, specialty care, but certainly we have been supportive of legislation, specifically, as I mentioned, the Opioid Workforce Act and Substance Use Disorder Workforce Act, that would provide physicians to help with those mental and behavioral health specialties. And as well as you saw back in the CAA back in 2020, those positions, there are criteria around those positions, where they should be allocated, what states, which hospitals, what specialties. All of those things are part of discussions and conversations we are part of and would love to be part of as we move forward and try to increase Medicare support for GME. I've always said that if at the end of the day, we are debating and discussing where these positions need to go, what specialties they need to be in, and how many there are. That is a great place for us to be, because I think it's then, you know, a recognition of the problem and the need for more. So we are running short on time, but I think we've got another, if we have time, maybe just one more question. And I would open this up to the entire panel, because I think you all perhaps will have this perspective. Can you talk about how large urban academic medical centers can help reduce the inappropriate use of emergency departments by adults with severe mental illness who are often uninsured or covered by Medicare, SSI, or Medicaid?
I was typing a response, but I'll answer it sort of quickly. So we are an essential hospital, Metro Health. We are, public system. And so this is something that we've really tried to take a multi-prong approach. One of it is starting from, remember I mentioned prevention and early intervention, is really looking at some of those social determinants of health and really looking at how do we treat some of the factors that really lead to repeated emergency department use, empowering communities, families, providers, and individuals in recognizing emergent symptoms of mental health crises, and also understanding that there are certain stressors that, if left untreated, again, we call, high utilization. And so we also have specific intervention and care coordination around identifying some of those patients and individuals that may be more likely to use. So I think we have to really educate on roles and responsibilities within mental health and understand that emergency rooms and urgent care often are places where individuals will go to seek support. And so how are we really wrapping around and understanding the factors that are leading to that usage? But again, we're a public hospital. And so this is something that we are addressing regularly and really trying to make a concerted effort to dial back and move upstream.
I can just add, as someone who came from a more large urban hospital before UVA, I think this is part of the promise of integrated care and primary care and specialty care is this earlier detection and receipt of intervention. Also, other urban hospitals have utilized other types of programs like ACT, assertive community treatment, to have behavioral health providers go out in the community, which there's some data to show that also helps with reducing emergency visits for psychiatric reasons.
So I am, I can't believe it's 1:03. We've gone over. I want to thank our panel. I thought that was an amazing briefing, amazing presentation. Just such great work. Just to remind our attendees that all of these materials and additional information will be made available. Please feel free to reach out to us with any questions or concerns. We're happy to make connections and help you make connections. And with that, I want to thank everybody for joining us today, especially our panelists and our team who helped pull off this great briefing. So thank you very much, and we look forward to talking to everybody soon.